Hello everyone. Today we will be covering the theory and the protocol that guides to measuring pulse and blood pressure. Without further ado, here we go. Let's begin. The average heart for the young adult varies depending on age, physical size, genetics, and activity. Usually it's within the range of 60 to 100 heartbeats per minute. The fitter you are, the lower your resting heart rate is likely to be. An athlete may have a resting heart rate closer to 40 heartbeats per minute. After each heartbeat, there's a pressure wave being created along the artery, which causes the arterial walls to bulge and then contract. These pulses can be felt at various different points throughout the body. One example is on the wrist. So, why not? Let's take the pulse. So, sit down and relax to take a resting pulse. Place your first two fingers on the inside of your wrist. Feel for a strong pulse and count the beats for 30 seconds. Multiply that number by 2 to get beats per minute. If you can't feel a pulse on the wrist, try checking under your jaw, the carotid artery. Be careful as this makes some people lightheaded. If your pulse feels irregular, try checking for 60 seconds instead. The beat should be steady and regular, but irregular beats will be noticeable and out of rhythm. And as such, if your pulse feels irregular, talk to your healthcare provider. Now let's talk about blood pressure. If you lined up all the blood vessels in your body, they'd be 95,000 kilometers long. And every day, you can carry the equivalent of over 7,500 liters of blood. Though that's actually the same 4 or 5 liters of blood just recycled over and over, delivering oxygen and precious nutrients like glucose and amino acids, the body's tissues. All that blood exerts a force on the muscular walls of the blood vessels. That force is called blood pressure, and it rises and falls with the phases of the heartbeat. It's highest during systole, when the heart contracts to force blood through the arteries. This is your systolic pressure. When the heart is at rest between beats, blood pressure falls to its lowest, to the diastolic pressure. A typical healthy individual produces a systolic pressure between 90 and 120 millimeters of mercury, and diastolic pressure between 60 and 80. Taken together, a normal reading is about a bit less than about 120 over 80. The blood traverses the landscape of the body through the pipes of the circulatory system. Any plumbing system, there's several things can increase the force on the walls of the pipes. The properties of the fluid, extra fluid, or narrowed pipes. So if the blood thickens, a higher pressure is needed to push it, so the heart will pump harder. A high salt diet will lead to a similar result. The salt promotes water retention, and the extra fluid increases the blood volume and blood pressure. And stress, like the fight or flight response, releases hormones like epinephrine and norepinephrine that constrict key vessels, increasing the resistance to flow and raising the blood pressure upstream. Blood pressures can usually handle these fluctuations easily. Elastic fibers embedded in the wall makes them resilient. But if your blood pressure regularly rises about 140 over 90, what we call hypertension, and stays there, it can cause serious problems. That's because the extra strain on the arterial wall can produce small tears, and when the injured tissue swells up, substances respond to the inflammation like white blood cells collect around the tear. Fat and cholesterol floating in the blood latch onto it, eventually building up to form a plaque that stiffens and thickens the inner arterial wall. This condition is called atherosclerosis. It can have dangerous consequences. The plaque ruptures, blood clot can form, clogging the already narrow pipe. If the clot is big enough, it can completely block the flow of oxygen and nutrients to the cells downstream. Vessels that feed the heart, that can cause a heart attack. And of course, oxygen-deprived cardiac muscle can die. If the blood cuts off blood flow to the brain, it can cause a stroke. Now, let's talk about taking the blood pressure. The Korsakoff sounds are rhythmic noises heard in the artery being partially compressed by blood pressure cuff. It occurs when compressive pressures between the person's systolic and diastolic pressures. At pressures higher than systolic, blood flow is cut off altogether. If pressure is lower than diastolic pressure, there's no compression of the artery. But when the pressure is in between the systolic and diastolic pressure, the artery alternates between compressed and open, creates the turbulence, causing the Korsakoff sounds. Something called the auscultatory gap occurs in a small minority of patients. If it's present when there's a range of blood pressures between the systolic and diastolic pressure, there's no Korsakoff sounds. Observed in older patients with a wide pulse pressure, that's a difference between the systolic and diastolic pressure. Auscultatory gap is important because if you fail to identify its existence, you can underestimate systolic pressure or overestimate diastolic pressures. The equipment for blood pressure measurement is simple. Standard stethoscope, something called a sphygmomanometer. Most people call this a blood pressure cuff, which is a misnomer. So, the parts of the sphygmomanometer includes the pressure gauge, the inflation bulb to inflate the cuff, and a one-way valve which can be twisted to regulate the flow of air. Depending on your equipment, the gauge can be mounted on the wall, attached to a stand, or actually small enough to be the best timing of blood pressure measurements. Blood pressure varies throughout the day and can be temporarily affected by exercise or caffeine consumption within the prior 30 minutes. For patients taking antihypertensive medications, it's preferable to take the measurement of blood pressure immediately before the meds, or usually taken through. This is not often practical, however. If patients have been complaining of lightheadedness, that could be due to excessive hypermedication. So what's the actual procedure? First, this is often omitted in practice. It's recommended the patients empty his or her bladder. A full bladder may slightly elevate the blood pressure. Also, the patient should be resting in a quiet room for about 5 minutes beforehand. Once the patient has been resting in calm and we wash and sanitize your hands, we can begin. Next, the patient should be properly positioned. For ambulatory patients, this means seated with back supported, both feet flat on the floor, with arms supported at approximately level of the heart. If there's a tray or table which the patient can rest their arm, you will need to support the arm for them while performing the measurements. Failure to properly position the patient may result in elevated rhythm, which does not represent the true blood pressure measurement. Mostly it doesn't matter which arm you choose, however, there's some circumstances when it does. The most common of the situation for patients who are on hemodialysis, whom you should actually avoid the measurement of blood pressure on the same arm as hemodialysis access. Make sure the upper arm can be exposed without constriction from a tightly rolled up sleeve. Otherwise, the patient will need to remove the outer layer of clothing. Make sure to select the proper size cuff. Most have about 4 or 5 size of arm cuff ranging from infant to a large adult with an extra large size labeled thigh. Length of the cuff, bladder should be about 80% of the arm circumference. Many cuffs have a helpful guide printed inside the cuff. There's a range that you can see. If it falls within the range, the cuff is good. If it doesn't, you need to look for a different size. In a rare occasion where the patient's arm is too large, you may need to use an adult thigh cuff. Wrap the cuff around the arm with the bottom edge 2 to 3 centimeters above the elbow. There's an arrow, should be lined approximate artery of the brachial artery. In order to avoid problems with the auscultatory gap, the systolic pressure should be estimated through the pulse obliteration pressure. Let's go ahead and take a look. Ignore your stethoscope for a moment. Instead, place 1 or 2 fingers along the radial pulse. Once you're confident you can feel it, turn the valve to the closed position and slowly inflate the cuff until the pulse disappears completely. The pressure at which that occurs is approximately the systolic pressure. Once you have an estimate of systolic pressure, place the stethoscope over the brachial artery where you can tuck in the edge of the stethoscope bell. Inflate the blood pressure cuff to about 30 millimeters of mercury above the pulse obliteration pressure, and then slowly decrease the cuff pressure by 2 to 3 millimeters for each heartbeat. At one point, you will then start to hear the Korthoff sounds. The pressure at which you hear the very first thump is the systolic pressure. You continue to slowly lower the pressure. The sounds will start muffling and then disappear altogether. Although in the past, some experts have said to use the muffling pressure or sounds as the diastolic pressure. But realistically, when the sounds totally disappear, that's where your diastolic pressure should be read. Continue to lower the pressure to about lower than 10 millimeters of mercury to ensure you've accurately identified the diastolic pressures. The procedures should be at least performed twice. The final recorded pressure should be the average of all the recordings taken at the same sitting, rounded off to about 2 millimeters of mercury. You may observe the gauge needle beating actually during the Korthoff sound. It may be tempting to use this visual observation as a surrogate for auscultatory measurement, but this is not advised. There might not be a complete agreement between the visual and the Korthoff sounds. Don't forget to tell the patients the result after you're done. That is it. Thank you for watching. Much appreciated. Take care. Enjoy. See you soon.